Good morning to you all and welcome to this first session on day 3 of the 75th conference of the All India Ophthalmological Society. We have actually a very interesting course on diagnosis and management of vitreomacular interface disorders. Actually, a lot of interest has evolved over the last couple of years in understanding the vitreomacular interface thanks to development in SD-OCT and a lot of changes as far as the management of many of these diseases are concerned. And over the years, thanks to development in technology, I think the visual outcome of some of these disorders has improved significantly. We have a very interesting panel of instructors for this particular instruction course. And without much ado, let us start the instruction course. I would like to introduce also Dr. Süleyman Kaynak from Turkey. Sir, can you just stand up? He has come from Turkey and he'll be giving a keynote address at the end of after the other speakers have finished the course, so that we have a reasonably good crowd for Dr. Süleyman. So our first speaker is Dr. Anubhav Goyal, who is a consultant vitreoretinal surgeon at our institute. He will be talking on SD-OCT morphology and classification of VMI and VMT. I request all instructors to please stick to your time because we need to finish the course on time and we should have some time for discussion. Thank you.
Thank you, sir. Slides, please. Good morning. Welcome you all. As we all know that OCT is the most important screening tool nowadays, and with the advent of third generation OCT, this has dramatically changed our understanding in vitreomacular interface disorders. Posterior vitreous detachment is an inevitable aging process, and it usually starts at macula and it's complete after it separates from the optic disc. PVD is clinically seen as a V's ring, but on OCT it is uniform. It is seen as a uniform hyperreflective white line, which in a partial PVD it is seen attached on disc, and complete PVD is seen separated from the disc. Early cortical liquefaction with abnormal adhesion between the vitreous and ILM is main culprit in causing vitreomacular interface disorders. International Vitreomacular Traction Society has given a classification system and defined vitreomacular adhesion, traction, and full thickness macular hole. So first of all, first entity, vitreomacular adhesion. It is seen in eyes with partial PVD. Usually macula has a normal contour and patients are asymptomatic. They have divided this VMA in focal and broad. Focal is less than 1500 micron, broad more than 1500 micron. There is a scan showing normal foveal contour with small area of adhesion. This is a scan showing large area of adhesion with normal foveal contour. This is called broad vitreomacular adhesion. If it is associated with other concurrent problems like diabetic retinopathy or wet AMD, it is called concurrent vitreomacular adhesion. Second entity, vitreomacular traction. It is also seen in partial PVD cases. Usually in these cases, patients have distorted foveal contour and patients are usually always present with visual symptoms. Most common symptom is metamorphosia. It is also classified in focal and broad. Focal is less than 1500 microns attachment and broad is more than 1500 microns attachment. This is an example of focal attachment. You can see just inner layer distortion. If it is more strong, it can cause inner layer cavitation, which is seen as foveal pseudocyst. If it is further increased, it may worsen the macular structure and cause more traction, which is later named as vitreomacular traction syndrome. This entity practically needs surgical intervention to improve the visual status of the patient. Broad vitreomacular traction, it usually causes distortion of all layers of macula in the whole area of attachment. If this is an OCT showing a small SMD, vitreomacular traction can cause pulling of fovea, which actually forms a pseudo SRF instead of actual SMD. If it causes damage of inner layers, it can present as a schisis. If it is attached at disc, called as papillomacular traction. Concurrent means when it is associated with diabetic retinopathy or wet AMD. Retinal membrane. It is a remnant of posterior vitreous even after complete PVD, and if it is very minimal and not distorting the macula, it is usually asymptomatic. And but if increases in thickness, it distorts the macula, and this puckering causes significant visual symptoms which may warrant surgery. It can be associated with retromacular traction. Third entity is full thickness macula hole. It is full thickness defect in fovea and cause significant visual defect. It is also divided into small, medium and large. Small is less than 250 micron size, medium is 250 to 400 and large is more than 400 micron size. The parameter what the society has taken is minimum hole diameter. Old gas classification has a problem. It is basically based on clinical examination, but this newer OCT based classification is more precise and reproducible. It can give us better understanding and for better intervention. This is an OCT of impending macular hole. You can see inner layer cavitation with vitreomacular traction, which in some cases can land up into full thickness hole. Full thickness macular hole can be associated with partial PVD. You can see attached posterior hyaloid at the margin of the hole. It can also be associated with full separation of vitreous. You can see operculum overlying the whole area. This is a serial scan showing vitreomacular adhesion to traction and further leading to full thickness macular hole. So clinically, this full thickness hole can mimic lamellar macular hole or pseudo hole. What are these? Lamellar hole is seen as a defect in inner layers, but the outer layers usually intact, and it will cause very minimal visual symptoms for prolonged period of time. Pseudo hole, though clinically looks like full thickness hole, but initially on scans you can see it's actually a thickening of macula with heaped up foveal edges, and there is a concurrent associated ARM with central opening. OCT-wise mimickers of adhesion vitreomacular traction is macular telangiectasia. The only difference in both these entities in macular telangiectasia, you will see macular thinning, foveal thinning. But in all these vitreomacular interfaces, you will see macular thickening instead of thinning. So take home message, OCT can elucidate anatomic changes in vitreomacular interface disorders. A careful examination and knowledge of underlying pathology can give better identification of vitreomacular disorders. Appropriate diagnosis of interface disorders can help in better management and thus final visual prognosis for the patient. Thank you.
Thank you, Anubhav, and you can please sit down here. We'll have the discussion at the end of the session. I just want to say one comment that we need to differentiate between a vitreomacular adhesion and vitreomacular traction. In an adhesion, the foveal contour is normal. In a traction, the foveal contour is abnormal. So this is a basic difference, and most often patients with adhesion may have a very good visual acuity, but patients with traction may have significant visual defect, especially metamorphopsia. So we'll go on to the next talk, which is a very important talk on vitreomacular traction and impending macular hole. What are the options in management? This is something which we come across very often in vitreoretina practice. And as Dr. Anubhav Goyal defined, what is vitreomacular traction? It is the presence of perifoveal vitreous cortex detachment with an attachment of the posterior hyaloid to the macula, at least within an area of about 3 millimeters involving the fovea, resulting in distortion. You can see here in this particular picture, the top picture shows you early vitreomacular traction, where there's a distortion of the fovea and also a slight loss of tissue in the outer layers of the retina, but the ISOS and the external limiting membrane are normal. Therefore, the patient may have very good visual acuity, may have mild metamorphopsia. But as it progresses, you can see the picture on the bottom where there is significant vitreomacular traction. The hyaloid is raised further. There's a minimal attachment to the fovea. There's a loss of the ellipsoid layer on the outer retinal bands, and this sort of patient may have significant visual defect apart from metamorphopsia. So the second one is probably a significant vitreomacular traction and can be an impending macular hole. What are the symptoms? The symptoms are metamorphopsia and defective vision. These are the two important symptoms, and this varies depending on the degree of traction and also how much it has affected the outer layers of the retina. As far as the management options are concerned, first is observation. So, there are a lot of people who observe some of these patients. Now, there are a lot of studies which have been done where they have observed the long-term effect of observation in patients with vitreomacular adhesion managed by initial observation. This is the most recent study published in 2014, where 106 eyes of 81 patients were followed up for a mean of 23 months, and about 28 to 30% of these patients had spontaneous vitreomacular separation during this period of time. But this is the only study which shows such a large percentage of patients showing spontaneous vitreomacular separation by observation. There's a very old study, very popular one, done by Hikichi et al. From Japan. This was done way back in 1990s when OCT, the first generation OCT, was available. This was for a longer period. Mean follow-up was for about 60 months, but only 11% of the eyes showed spontaneous vitreomacular separation. And more importantly, most of the patients in the series showed further worsening of visual acuity, and the question of observation as a form of a treatment was questioned in this particular study. The second option in management is a more recent concept, which probably many of you may not be used to, what we call as intravitreal gas injection. This is what is known as a pneumatic vitreolysis. And during the last 3 years, there have been a lot of publications about pneumatic vitreolysis. What we do is we do an intravitreal injection of 100% C3F8 or SF6 gas, 0.3 ml, and then the gas bubble massages the posterior pole. And because of the buoyancy of the gas, there's a massaging of the posterior pole that results in vitreomacular separation. So one of the techniques described as a drinking bird, where you just ask the patient to lift the head and bring it down, lift the head and bring it down, so that the gas bubble moves in the posterior pole of the retina. There are studies where they have done a face-down positioning for a short period of time every hour for the first 3 to 4 days. And there are studies which say that you don't need to position at all. The movement of the gas bubble takes care of the problem. I have tried this in a particular case. This is a nurse, 59 years old, very educated woman who came with significant metamorphopsia. She had a visual acuity of 6.9 in the left eye. You see the OCT, there is significant vitreomacular traction and impending hole. Patient very symptomatic. She said she is not able to give the intravenous injections at all, and she is finding it very difficult. And however, I was convinced her to wait for some time. 1 month later, getting worse, visual acuity has worsened, traction has increased. At this point of time, I did 100% SF6 gas injection, and I did the drinking bird exercise. And you can see here there is progressive release of the complete vitreomacular separation, which occurred within about 10 days. And if you see here, there is significant separation. And I could follow her up only for a month or so because she returned back, but she wrote back to me saying she is far better and her visual acuity improved to 6.9. And this is another study, one of the earliest studies of this particular technique, where they found that 40% of the eyes had spontaneous vitreomacular separation with gas injection, which is more than what has been reported with ocriplasmin. The complications are very less incidence of retinal tears. This is a more recent study using intravitreal sulfur hexafluoride, where again they have noticed about 40% spontaneous vitreomacular separation with pneumatic vitreolysis. The third option is vitreous surgery, which probably is the most common technique that we are using. There are a lot of small papers on the use of showing the anatomical and visual outcomes of vitrectomy for vitreomacular traction. The results are very good, and we have done it in a large number of cases. I do it in a lot of my patients who are highly symptomatic. They may have a visual acuity of 6.12, 6.9, but if they are highly symptomatic and that's really troubling them, we need to help them. And one of these patients whom I operated already had a macular hole in the other eye. And when I operated her in that eye, I told her, you were a little late. That's why your visual acuity has not improved. So she questioned me as to, why don't you operate this one now? Why are you thinking? Because I come so early. So the results are good. You can see the pre-op and the post-op. Here also you can see the pre-op and the post-op. The drawbacks of vitrectomy, of course, of progression of cataract, but other complications like retinal tears, detachment, infection are all quite rare now, especially with microincisional procedures. The last is pharmacological vitreolysis, which unfortunately we do not have access to because we do not have ocriplasmin, which is given in a single dose of 125 microgram. There are two landmark studies. One is the MIMI Trust trial, where the spontaneous vitreomacular adhesion resolution at day 28 after injection of ocriplasmin was only about 26.5%, which is much less than pneumatic vitreolysis. However, there are a lot of complications. The most important complications is floaters and changes in the electroretinogram. In a subgroup analysis, you can see here, they're very interesting. Patients with epiretinal membrane do not do well. You need to have a macular hole of less than 250 microns microns for getting a good result of about 40%. Otherwise, the results are not very good. In a more recent study, that's the 2-year study of ochreplasmin, which was released recently, the number of patients who had spontaneous resolution was about 40% when compared to the 28% in the initial study in the MIVI Trust trial. But again, the complication rates were quite high, especially vitreous floaters, photopsia, etc. And also they studied the ERG changes, and 40% of these patients had ERG changes after the treatment, which was of course resolved in large number of cases, but definitely there are some side effects which is questionable. So how will I manage my patients with vitreomacular traction? Observation. I usually, if the patient is not very symptomatic, comfortable, I convince them to come back to me and I repeat the OCT and the visual acuity. Pneumatic vitreolysis is an option in treatment if the patient is educated and able to understand, so that you do it before you go in for a vitrectomy. And ultimately, in our situation, vitrectomy is the treatment that we offer in such situation. Thank you all for your kind attention. Any questions? Any questions or anything from the audience? So we move on to the third talk, that's on epiretinal membrane by my colleague, Dr. Mahesh. He's a senior vitreoretinal consultant and head of the department in our institute, and he'll be talking on epiretinal membranes.
Thank you, sir. My talk is on importance of SDOCT, selection of cases and surgical management of cases of epiretinal membrane. Idiopathic epiretinal membrane is an avascular proliferative fibroblastic membrane that forms between vitreous and ILM. And the prevalence is quite variable in different studies, and it is closely related to the PVD. And it causes defective vision, metamorphopsia, micropsia, and even monocular diplopia. So everyone should understand the pathology of ERM and VMT. Basically, all of us will have PVD, which has been described in 95% of cases in idiopathic ERM. The PVD, there are different, normal PVD will not cause any symptoms in any eye. But anomalous PVD is the basic pathology of VMT and ERM. So there was initially one theory was there, PVD causes breaks in the internal limiting membrane that allow cells to migrate to the inner surface of retina, where they form idiopathic ERM. But the theory has been challenged because there was no break found in the ILM routinely. So the concept of anomalous PVD came. There are two processes. One is vitreous liquefaction. Number two is that separation of the posterior hyaloid from the retina. If both have a mismatch, it will either result in ERM or a VMT. That is, if the liquefaction is very fast but it is not separated, some of the cells may remain on the vitreous surface, causing proliferation and ERM. So this is a table showing anomalous PVD and result in either VMT, macular hole or ERM. Now, it is very difficult to say that ERM, to differentiate the ERM from attached posterior hyaloid. You can use a B-scan, but it is not very sensitive. Classification of ERM, there are different classifications, mostly very confusing, but usually we divide it into primary or idiopathic and secondary ERM associated with all inflammations, diabetic retinopathy, retinal vein occlusion, etc. There are different classifications based on morphology in OCT, but it is very difficult to remember all those things, like this one, with PVD, without PVD, and all those difficult. But one of the recent classification is very simple: idiopathic, primary, secondary, and macular thickness, central foveal thickness based on OCT. Usually, I will come to the surgical management. The American Academy website, that their articles say that following vitrectomy surgery for idiopathic ERM, vision improves in by 2 or more Snellen lines in more than 2/3 of the cases. And the most important thing is visual recovery starts little late, 2 to 3 months, and up to 1 year it may improve. Beyond that, it may not improve. So most patients will have an improvement in metamorphopsia during the first month following surgery. And it depends on a lot of other factors also. So initially, if the ERM has very poor vision, your outcome also will not be very good. In the sense, if it is county figure 1 meter, he may improve to 6/60, not beyond that. But the visual improvement may be more if the initial vision is bad. So other retinal vascular leakages, cystoid macular edema, and all these factors will have adverse events in the outcome of ERM surgery. Prognostic factors include basic ILM profile and foveal contour has no significance in the best corrected visual acuity, but integrity of external limiting membrane, ellipsoid line has influence on the final visual acuity. Postoperative integrity of ELM and ISOS ellipsoid line has an important, so that is important in the surgical management. The latest systematic review of prognostic factors of epiretinal membrane showed that visual acuity outcome, so the shorter duration of symptoms before surgery, lesser central foveal thickness at baseline in OCT, good integrity of ellipsoid line, and thinner ganglion cell inner plexumum layer at baseline had better outcome in ERM surgery. Now, who is the good candidate for surgery? A patient who is symptomatic. You have found something on accidental examination and do something, he will never be happy. So, if patient is symptomatic, reasonably good vision, not very bad county finger 1 meter with that may not be a very good candidate, because improvement also will be proportionate. Usually between 6/12 to 6/60 is the ideal. There is no comorbidity like ARMD or inflammation, and patient is pseudophakic. If the patient is phakic with cataract, you can deal it along with the ERM removal. Decision making is very important, because many times the patient comes with cataract and ERM. You are in a fix whether the cause of defective vision is cataract or ERM. If the cataract is significant and ERM is also significant in OCT, you can manage it combined. Otherwise, you can do a cataract surgery, tell the patient we will deal with the ERM later. So this outcome prediction, even in experienced hand, it is sometimes difficult. I will show a few cases. This was a 64-year-old male, metamorphopsia recently noted while closing the other eye. This was preoperative OCT. You can see the ERM in multiple layers. The OCT, spectral OCT, will help you to peel. Where to start the peeling, where is the cleavage, you will know from the spectral OCT, and spending 5 minutes in front of the OCT before surgery will help you a lot of time during the surgery. So this is pre and this is postoperatively. And just one thing, that none of the ERM patient will be very, very happy. They will be okay. Suppose you counsel them, they will be okay. So they will not be as happy as other disease, retinal diseases. So patient was quite okay, 6, 12 and 10. I demonstrated that you have improved in OCT and clinical examination. Then this was another case of 70-year-old female accidentally detected defective vision, which usually is the case. They may think that they have cataract and they will not come for a long time. Then they come. So this is quite a bad ERM, thick ERM, and fovea is totally distorted. So I gave not a very good prognosis, but operated. So there are some intraoperative factors that you should take care. Usually, as I said, there will be PVD, but many of us stain with triamcinolone initially to see the PVD. The little triamcinolone inside will take care of the macular edema also. That is another use. A lot of people use trypan blue to stain the ERM, and then after removing the ERM, again put brilliant blue. The other one method is put brilliant blue and start the ILM peeling from the periphery, and while removing the ILM, ERM also will come off. These are all different techniques, but individual preferences. So this is just peeling just with, you can see the cleavage based on OCT, and where there is a cleavage, and it is always important to peel, not to have a lot of traction in the fovea. Sometimes you can de-roof if there is a cyst at the fovea. This one I showed there was no cyst or anything at the fovea. So the chance of de-roofing was less. So it is always peel, avoiding traction at the fovea. So this, I use contact lens rather than biome or recite while doing this, because of stereopsis is important. So it is important to peel without much of a damage in the retina. So after removal of the membrane, we can stain with brilliant blue and peel the ILM also. This is a controversial step, but most of us do ILM peeling also with ERM removal. Some cases where we have left, the chance of recurrence is little high. So this is preoperative and this is postoperative. Preoperative and postoperative. Patient improved to 6/24. Not very happy, but I convinced that you are very lucky. Now the case 3, this was, I have seen this man in 2013 with distortion of images, and this multiple layers ERM with VMT was there, operated, cataract with vitrectomy, and the vision dropped to county finger 2 meter, it became a macular hole. So this is what I was telling, while peeling the ERM, if there is a cyst like that, you should not de-roof the cyst. Patient, I suggested resurgery, but it didn't come. But after 2 years, he came with a closed hole. Very rare, after 2 years, the spontaneous closure. So the peeling also, it has to be very non-traumatic while peeling the. This was another case of 61-year-old man with 6/18 vision. This was a VMT case, in fact. I advised surgery, but he was refused, and he came after 2 years. The PVD has occurred, but there was a ERM. So since the vision was quite good and it was accounting to the cataract, I advised only cataract surgery. But after cataract surgery, his ERM started separating, resulting in macular edema. Patient was very unhappy, and gradually this edema subsided, is little getting better. So there are a lot of unpredictable factors in deciding ERM surgery, even in experienced hands. So this is the last case, I think, metamorphopsia, deterioration of vision from 6/9 to 6/18 over 1 year. So this is pre-treatment and post-treatment. This is the post-op. It has become flat, but the patient has severe complaint of anisoconia, that with that eye he is seeing small compared to the other eye. So pre-op and post-op, very unhappy due to anisoconia. There are a lot of factors. There is foveal thinning. Probably I waited for a long time for vision to drop. So this is, so take-home messages are, operate the case if there is documented worsening of vision, operate if symptomatic. The vision, very bad vision and very good vision may not be good candidates. We can always observe very good vision. Poor initial vision means poor final vision. Proper communication is the key to the success of ERM. And assessment of cataract with ERM may mislead you. Timing of surgery is, as I already told. And what can be expected in a case, you have to communicate it to the patient very carefully. Thank you very much.
Thank you, Mahesh. I think it was a good presentation with some cases. I just want to add a few more points. As he said, the preoperative visual acuity is very important in deciding. You may see patients with a 6/9 vision or a 6/9 N6 vision with an epiretinal membrane, and probably these are cases which we normally observe because the visual acuity is very good and we do not operate. Probably 6/18, 6/12, and if the near visual acuity is bad, N10, etc., definitely we operate. And if you operate on patients with reasonably good vision, usually the visual improvement is better. Regarding the peeling technique, as he demonstrated, we identify the edge, we release the epiretinal membrane bit by bit from one end to the other. We don't just pull at one corner and then drag it like that. Release it little by little so that the whole epiretinal membrane is released as one total membrane, and so that the traction that we exert on the fovea is reduced significantly. So if the membrane is seen very well without staining and we can see the edge, you don't need to stain to remove the membrane. You need to stain to remove the membrane only if the edge is not visible to you on examination. Then obviously we have to stain and identify the edge. And removing the internal limiting membrane, I think we have one more talk by our keynote address, and after that probably we can discuss about the advantages and disadvantages of internal limiting membrane peeling. So if we move on to the next talk, that's on outcomes in macular hole surgery. Dr. Modi is a consultant at Narayana Nethralaya, Bangalore, and this is part of a study that was done, and I thought that it will be interesting to hear this particular presentation.
Good morning, everyone. And first of all, I would like to thank Dr. Giridhar for giving me this opportunity to present our work, actually, which was done at Giridhar Institute. Interesting work. So I'll be presenting outcomes in macular hole surgery and whether size of ILM peel matter. It's a very, very important question, which is always there at the back of vitreoretinal surgeon's mind. How much ILM to peel? Probably most of the time we go ahead with the approximate thing, how much, we are used to. So whether there is any scientific logic of increasing or decreasing the size of peel and whether it really matters anatomically or functionally. So without acknowledging the legends, I don't feel we should go forward in any presentation. So just these two gentlemen, I would like to remind Knapp and Ojalvi, who actually discovered and named the term, they gave the term macular hole. So how exactly the game is played, I think it's very simple. We already know that there is some tangential traction, there is some anteroposterior traction, which ultimately results in a picture like this, which is clearly evident in the follow-up scans of this particular patient we had, in which hole progressed from stage 1 to stage 2 to stage 3 and finally to stage 4. So anteroposterior and tangential traction are very, very clearly evident here. So how to treat this? 3 very basic steps. We remove the anteroposterior traction by vitrectomy, we remove the tangential traction by ILM peeling, and finally we flatten and reposition the edges of macular hole by injecting endotamponading gaseous agent. So it all appears quite simple. So macular hole surgery is actually simple, nothing complicated in that. But is there any need to optimize? Yeah. So as I said, these questions are always at the back of our mind, that how much ILM to peel, whether large ILM peel is better for anatomical or functional outcome, or whether large ILM peel would help us in case of large holes or stage 3-4 holes or chronic long-standing holes. Then which gas is better, then whether long-acting gaseous endotamponade is better in large holes, chronic holes or stage 3-4 holes. So in the next 5 minutes we'll discuss regarding the ILM peel. Is ILM peel indispensable? Do we need to peel ILM in all our cases? So yeah, this is a large meta-analysis of 4 randomized control trials, and it was published in this Cochrane database, and they concluded that the closure is much better in the ILM peel group as compared to non-ILM peel group. But there's always an other side of the coin. So there are multiple studies. See, these 2 studies, one of them published in ophthalmology, which reported significant thinning of ganglion cells and inner plexiform layer at 6 months post-op visit. And one report published as overall thinning of retina temporal to fovea post-ILM peel. So we have an idea that since we are peeling ILM, which is a normal part of the retina, there are definitely some architectural changes in the retina. So this was one more study, very interesting. They concluded that ILM peeling reduces retinal sensitivity and significantly increased the incidence of microscotomas, and that it is justified to avoid peeling the ILM when its potential benefit seems minor or unproven, probably in stage 1 holes, and when peeling is actually carried out to limit the surface peel to the bare minimum. So what is bare minimum? So we wanted to find out what is this bare minimum. So we conducted one study of our own and recently published it, that what we did was, we made 2 groups, so group 1, group 2. In group 1, we peeled approximately 2 disc diameters of ILM, which we named as 3 mm ILM group. 25 eyes were recruited in that group, and another group we peeled approximately 3.5 disc diameters of ILM, that is 5 millimeters. So how we did that? So preoperative, we made a circular grid, we superimposed it on the fundus photo, we projected this photo in front of the operating surgeon, and we peeled depending upon the 3 mm or 5 mm recruitment, the group. Finally, the post-op analysis, we used our Heidelberg automated segmentation software, through which we can analyze each and every layer. So since ILM rests on RNFL, so I thought we'll analyze RNFL, what is happening to the RNFL layer. So both the groups were matched demographically. Both the groups were matched as far as macular hole anatomical architecture was concerned, like mean diameter, base diameter, height, macular hole index, so that the 2 groups are comparable. Then these are the closure rates. So the closure rate between the 2 groups, we didn't find any difference. Then depending upon the staging, depending upon duration, we divide the macular holes like less than 6 months duration, more than 6 months duration. Both the groups, the closure rate was the same. Then finally, depending on macular hole size, less than 400 microns, more than 400 microns, again, there was no difference in anatomical closure rate irrespective of staging, size or duration. So closure rate was the same, even the closure type, the ratio type 1 is to type 2 were the same in both the groups. As far as the RNFL layer is concerned, so there was a difference. So in group 2, where we peeled 5 mm of ILM, and in group 1 where we peeled 3 mm of ILM, so as we move away from the fovea, so at the location 2.5 millimeters from the fovea where ILM was peeled in group 2 but not in group 1, so the RNFL was found to be thinner, that is 14 which is the blue line. So it was thinner in group 2 as compared to group 1. So definitely there was some atrophy of RNFL in the area where ILM was peeled. As far as visual acuity is concerned, this was an interesting finding that in group 1, that is the 3 mm peel group, the improvement in visual acuity was 0.41 logmar, and in group 2, the improvement was 0.14. And there was much more improvement in group 1, and the difference was significant. As far as outer layer restoration is concerned, there was absolutely no difference between the two groups. So till now, there has been no definitive direction as far as the amount of ILM to be peeled for successful repair of macular hole, with minimum possible architectural damage to inner layers. But the current study outlined the fact that greater amount of ILM peeling has no direct anatomical or functional advantage. Rather, it worsens the visual outcome of the procedure with greater damage to the macular retinal nerve fiber layer. So decrease, and this was substantiated in many other studies like this one published in Retina in 2012. So the authors concluded that there was decrease in inner macular volume. The same thing we also found out, there was atrophy in RNFL layer. So there was decrease in inner macular volume in this particular study following ILM peel and as a part of surgical repair for idiopathic macular holes, and it correlated worsening of visual acuity post-op in anatomically successful surgery. So there was functional implication of ILM peel. So this was regarding RNFL. So we decided to investigate further, like, what is the, damage happening at the deeper layers or outer layers or all the 10 layers. So we conducted one more study. So this was spectral domain coherence, optical coherence tomography based microstructural analysis of retinal architecture post ILM peel for surgery of idiopathic macular hole repair. In this surgery, we recruited 50 patients with minimum peel of 3 mm diameter. Again, we used the same segmentation software, but the difference was that we analyzed each and every layer individually, preoperatively and postoperatively at the same location. Same location means 1.5 millimeters from the fovea, medial and lateral. So what did we find out? So since the architecture of retina is different medial to the fovea and it's different lateral to the fovea, so our findings were also different at the medial location and at the lateral location. So these are the findings at the medial location. So interestingly, we found out that the overall thickness of the retina increased significantly medial to fovea. And the overall thickness increase in retina corresponded to the overall thickness in inner retina. So which was the layer which was significantly affected? That was inner nuclear layer. But the ganglion cell layer was only layer which showed decrease in thickness, even medial to fovea and lateral to fovea, that we'll see later. So these were the findings that we found out, 1.5 millimeters temporal to fovea. So temporal to fovea, we found out exactly the opposite thing, that is atrophy. The whole atrophy came from the inner layers, with the majority of the thing coming from ganglion cell layer. You can make out the ganglion cell layer thinned out from 41 to 30 microns, which is 25% of the overall thickness, and inner plexiform layer thinning out from 45 to 33. Again, very, very significant finding. So we conclude that there was significant alteration in the inner retinal architecture. Definitely there is. Post-ILM peel after vitrectomy, retinal thickness increased medial to fovea while it demonstrated significant thinning in the temporal quadrant. Then layered analysis demonstrated maximum thickening in inner nuclear layer medial to fovea, while GCL was the layer to demonstrate maximum thinning in the temporal quadrant. So ganglion cell layer was the only layer to demonstrate thinning in both quadrants, but there is definitely alteration in retinal architecture overall, in all the 9 layers. So the take-home points are ILM peel forms a necessary step in surgery for idiopathic macular hole repair, that we all agree. It is imperative to remove ILM from the edges of macular hole to relieve tangential traction rather than increasing the diameter of peel. So diameter of ILM peel has no implication on anatomical closure rate. That is what we found out, which is rather influenced by other factors like macular hole dimension, indices, probably etiological factors. ILM peel definitely alters the architecture of neurosensory retina, which may have functional implications. So larger ILM peels does not seem to improve anatomical closure rates even in larger, long-standing or stage 3-4 macular hole. If the hole has to close, it will close with 3 mm also. If it doesn't have to close, it won't close with 5 mm or 6 mm also. Rather, it increases surgical time, requires multiple pinches, and increases chances of vascular avulsions and retinal breaks. Thank you.
Thank you, Modi. And any questions? Very basically.
Aditya, excellent work. Hats off to you. I just wanted to know one thing. Why did you not add microperimetry to know the functional outcome? Because you concluded by saying probably with microperimetry added on to this whole great whatever work you have done, you would have given exactly that the functionally also there is an alteration. There is no alteration because microperimetry is a very simple tool.
Actually, that is a very good idea, sir. I mean, but we didn't have microperimetry at that time in our institute. That was the thing. But yeah, it's a very good idea. I mean, we even thought of that, microperimetry, and even multifocal ERG can be a very good thing to show us the electrical activity also. That would have completed the functional analysis.
But microperimetry gives you focal function, which is the unparalleled. There is no other test which can mimic it or maybe duplicate it.
Exactly.
So in such cases, probably a 3 mm or 5 mm peel would do you.
Yeah.
Excellent and very thorough workup. Nice one.
Thank you.
However, there were few questions, I went deep into the literature about the ill effects of staining.
Yeah.
So this was agitating my mind. There were 2-3 things which are damaging. First is the stain itself. And amongst the different stains, ICG is the most toxic.
Yeah.
Meaning if you have not even peeled membrane, the ILM, and have just stained it, and then done OCT, you would get some of these anatomical results like thinning. First thing. Second is the technique of how do you initiate the ILM peel. If it is a pinch and peel technique, then perhaps that focal damage is more, and that would come out well with microperimetry and multifocal ERG. So I thought if one of your next work could be just to stain and not stain and find out whether the results are comparable. That would tell us whether the staining has resulted in this damage or ILM peel. And then it doesn't give us the basis for a larger peel in a patient whose macular hole has not closed, and we revisit and do a larger peel and then it closes. So that incongruity in the observation and the data that you have presented remains a dilemma. Meaning, if it was not so, if ILM peel size was not to determine the success or failure of macular hole closure, then perhaps it would be unwise to revisit and do a larger peel and yet obtain a closure.
Yeah. No, the reason why I said any questions, I knew there will be questions because this is a controversial area where there are a lot of difference of opinion. But we have been doing many of us have been doing this surgery for many years, and always I have been having a feeling that the size really doesn't matter. And in patients who have a failed macular hole surgery, and when we do a re-surgery, the edges of the hole are cystoid. Even if you just inject gas and put them prone, sometimes it closes without even additional peel. But as I said, we probably cannot take the message from this article as a full-blown thing saying that the size does not matter. But it only questions whether the size really matters, because if the size does matter, we don't need to do ILM flap. We just need to do a large peel and all macular holes will close. So it's definitely a controversial area. So we move on to the next talk. Thank you, Modi. You can sit down. And thanks for all the comments. I think the comments are very good. And the role of microperimetry is good idea. And the role of doing this peeling without staining and seeing what it does, that's also a very good idea. Thank you all. So we move on to the next talk. That's by Dr. Rodney Morris. He's a senior vitreoretinal surgeon at Arvind Eye Hospital, Coimbatore. And he'll be talking on the next talk, that is on macular holes, ILM peeling versus inverted flap.
Thank you very much.
Please
sir.
keep to the time.
Thank you very much, sir, and good morning, everyone. At the outset, I'd like to thank Dr. Giridhar for inviting me over for this talk. So macular hole is a full thickness depletion of the neural tissue in the center of the macula, and Gass has described 4 stages of macular hole, stage 1 to stage 4. Poor prognostic factors in the case of macular hole are chronic holes, whole stage of the hole, and other pathologies that lead to a macular hole like traumatic macular holes, Fourier's Kaiser's macular holes, and myopic macular holes associated with RD. So there are some predictive factors. You have the hole form factor and the macular hole index. Macular hole index is the height of the hole divided by the base diameter. And the hole form factor is the sum of both the sides of the hole, slope of the hole, and the base diameter. So based on the base diameter, if the base diameter is less than 400 microns, it has a good prognostic and anatomical closure rate. In a study by Laura, she has proposed a base diameter size of 747 microns corresponds to a 76% sensitivity and 100% specificity for anatomical success. They went on to add that every 13 microns increase in the basal diameter, there's a 10% reduction in the odds for anatomical success. And likewise, a 26 micron increase in the base diameter, there's a 10% decrease in the odds for functional success. And again, the predictive factor, macula hole index, if it is more than 0.5, it has a greater improvement in postoperative visual acuity. And the hole form factor, if it is more than 0.9, was associated with an 80% success rate postoperatively. In addition to all this, functional predictive factors also includes the continuity of the retinal layers, the outer retinal layers. So if you have a continuous ISOS junction and an external limiting membrane, as well as an increased photoreceptor outer segment thickness, it predicts a better visual outcome. And types of closures, there are two types of closures. You have type 1 where you have a normal foveal closure with a normal foveal contour, and type 2 is where it's also called as a flat open macula hole. Or else you can have a U-type closure. The first one is a U-type closure. Then you have the V-type closure, and the flat open type is also called as the W-type closure. The treatment options available right now is ILM peeling. It's a standard procedure, which was described in 91 by Kelly and Wendell. And in 2010, for larger holes, inverted ILM flap was described by Mike Liska. The indications for the inverted flap are big holes, which is more than 700 microns of base diameter, macula holes associated with high myopes, traumatic macula holes, and for patients who cannot maintain a prone position. The concept or the idea behind an ILM peeling inverted flap technique is it acts as a scaffold for tissue proliferation, and the glial cell proliferation that is induced by this, it helps in to assume a new position for the photoreceptors in the proximity of the fovea, and thereby it improves the postoperative visual acuity. So these are the two techniques. The one on the left side is the traditional technique. After staining with the brilliant blue, you peel the ILM, and the ILM is peeled across the macula hole so as to not to leave any residual ILM in the margins of the macula hole, so that the success rate is much better. The second technique is called the inverted flap technique. This is the flower petal technique where you have multiple flaps created. It's brought to the edge of the macula hole, and then you start taking another flap in a similar fashion and it's brought to the edge of the hole, and it's done 360 degrees all around. There's another technique of inverted flap called the Trapdoor Technique, where you can peel it from the temporal side and the whole flap is placed across the macula to close the hole, to act as a scaffold. So, but this is a flower petal technique where the edges, the flaps are fashioned in such a way is brought to the edges, and the trimming, the final stage is the trimming of the macula, the ILM flaps. At that stage, you have to be very careful to reduce the turbulence within the within the vitreous cavity by reducing the bottle height and reducing the suction, so that you don't eat away the whole flap which you have painstakingly taken. And once the flaps are fashioned, the fluid air exchange can be done, and the residual flap can be fashioned into the macula hole using a soft tip cannula, so that the macula hole, it acts as a scaffold for the closure of the hole. Next one, whether to stain the ILM or not is again controversial. Some of us don't prefer staining. Some prefer staining, but staining will always help you to delineate the ILM in a better fashion. Over here, it's very difficult to see the ILM because only the pallor of the retina knows that the ILM is peeled over there. Whereas if you stain it, like in the movie Hollow Man, visualization makes it much better. So again, you have different types of stains for the ILM. You have the brilliant blue, you have the ICG, you have the brilliant trypan blue and the brilliant blue. ICG is very controversial because of its toxicity. It's not used nowadays. Then you have the trypan blue. The problem with trypan blue is you need to do a fluid air exchange, otherwise it stains the posterior capsule. And then you have the brilliant blue. So our experience is a 51-year-old lady, defective vision in the left eye of 1 month duration, 636 vision, phakic and stage 4 macula, full thickness macula hole. She underwent, you can see over here, the base diameter is more than 1000 microns. So the patient underwent an ILM peeling with an inverted flap. Brilliant blue was used, and this is the preoperative picture, and this is the postoperative picture with a type 1 closure. Another lady, again, in the left eye, full thickness macula hole, 612 vision, a phakic patient. And this patient, again, the base diameter is around 1500 microns, underwent ILM peeling, inverted flap, and ICG stain was used. And because ICG was being planned, we did a multifocal ERG before preoperatively and postoperatively. And there was no evidence on multifocal ERG tracing based on the retinal toxicity. We did a randomized, following this, we did a randomized study, and we had 2 groups. And each group consisted of 7 patients in the first group, which underwent the conventional peeling, and the second group of 5 patients, which they underwent the inverted flap technique, and only brilliant blue was used in all these patients. And routine preoperative evaluation was done. And here you can see the preoperatively, the hole was close to 1000 microns, 930 microns, and a perfect U-shaped closure following the peeling, the classical peeling. And this is an inverted flap peeling with the whole base diameter close to 1300 microns and a V-type closure. And this is another patient with, again, an ILM inverted flap technique was used. The whole basal diameter was around 1062 microns. And you can see the ILM filling the macula hole. So we had 2 groups. The first group had 7 patients. The second group had 5 patients. The male-female ratio was 1:6 and 1:4. Preoperative visual acuity was comparable. The base diameter in the conventional category was 1184 microns and close to 1400 in the inverted flap group. And you can see the the postoperative visual acuity improved marginally in both the groups. Closure rate was 100% in the inverted flap and 85% in the conventional flap. But the conventional flap had one hole non-closure, and the other one had all the 5 holes closed, one with the type 2 type of closure. So in cases where the closure or refractive macular holes, there are certain other techniques described. You have the anterior flap technique. When situations where you combining a cataract surgery with the ILM peeling, you can harvest the anterior capsular rhexis, the anterior capsule, and you can use that to bridge in the refractive macular holes. You can use that to bridge the macular hole for anatomical success, for it to anatomically successfully close the hole. So here you can see after the fluid air exchange, the anterior flap that has been preserved is placed in the macular hole and fashioned in such a way that it spreads across the macular hole. So in refractory holes, you can use either an anterior lens capsule, or you can also use a posterior capsule wherein a brilliant blue ICG dye is used to stain the posterior capsule. And then using a 25 gauge end gripping forceps, you can start the rhexis of the posterior capsule. And once the posterior capsule is being fashioned, it can be placed on the macular hole, across the macular hole, and then thereafter fluid air exchange can be done. In the last video, you can also use an autologous ILM transplant in cases where there is an unsuccessful closure of the macular hole. So here you can see the ILM, the residual ILM of the previous surgery has been stained with brilliant blue, and it's harvested. And this harvested ILM flap can be placed in the macular hole under a small PFCL bubble so that the displacement doesn't happen. So you can put a small PFCL bubble over here, and under the PFCL bubble, the harvested residual ILM can be placed in the macular hole, and thereafter you can do your rest of the procedure like fluid air exchange. Thank you very much.
Thank you. Rodney, any questions and comments? 2 minutes max. Rodney, when do you decide, basically, the inverted ILM flap, do you have any, what you call in your center that if the macular hole is this large or any particular feature, then such a situation I'll go and do a flap? Because, there may be many holes which may not close without the flap itself. It may close without doing a flap. So how do you really decide?
For idiopathic macular holes, always, if it's less than 700 microns base diameter, it's better to go for the conventional. And if it is more than 700 microns...
So you're taking the base diameter, not the minimum linear diameter.
No, not the minimum linear diameter.
The base diameter is more than 700. You're going ahead and doing a...
And then for the other types of traumatic macular holes and the myopic foveo Sky6 macular holes, it's better to always go with the inverted flap technique because the closure rates are much better in those.
Okay. Okay, if there are no questions, I think we move on to the next talk. That's by me. ये तो हो गया ना lamellar hole. Thank you, and we move on to the next talk that's on lamellar macular holes. I think we have got very limited experience as far as managing these lamellar macular holes are concerned. And again, in background, it was described way back in 1975 by Gass, many years ago, before even OCT came into vogue. And Gass felt that this is an abortive attempt at full thickness macular hole formation. Most importantly, most of these patients have got relatively good vision with a visual acuity of 20/40 or better. And the natural course is favorable in many of these patients in the sense that the visual acuity remains reasonably good over a long period of time. And over the last couple of years, there's better understanding with OCT. What exactly is an LMH? The first speaker already has defined what an LMH is. The most important points are the irregular foveal contour, there's a break in the inner fovea, and there's an intact foveal photoreceptors. I think there's a landmark study by Witkin and his group where they redefined the lamellar macular holes and vitreomacular interface using ultra-high resolution OCT. And most of the recent information is based on this particular study. So if you see this photograph, you can see the irregular foveal contour there. And you can see the break in the inner fovea. You can see the sciatic cavity, which is there. This is very characteristic of lamellar macular holes. And many of these patients have what is known as an epiretinal membrane. And there is a difference in the epiretinal membrane that we see in LMH compared to the idiopathic ERM. This is much more thick and hyper-reflective in OCT examination. So what is the pathogenesis? We really do not know. Many of us feel that it's aborted formation of full-thickness macular hole. But in patients where there is an epiretinal membrane, it's been noticed that many of these patients do not have a posterior vitreous detachment, and therefore probably the contraction of the epiretinal membrane is probably one of the etiological factors of LMH in such cases. So you can see this particular case where there is a vitreomacular traction resulting in a lamellar macular hole formation. Therefore, it's got a tractional etiology. And you can see in this particular case, there is no PVD, but you can see the thickened epiretinal membrane. Probably there is a contraction of the epiretinal membrane causing the lamellar macular hole. So as I had said earlier, the ERM has got very definitive characteristics. And actually between the ERM and the ILM, you see a hyperreflective area which probably is condensed vitreous. And 65% to 90% of LMH have ERM, and half the eyes with ERM and LMH do not have an PVD. What is the natural cause of lamellar macular holes? Now these again, there are a lot of studies which have been published in literature. And if you see all these studies up to a mean follow-up of about 60 months, the natural cause is favorable in a large number of patients. Therefore, when is surgery indicated for LMH? When there is progressive decrease in visual acuity, which can be described because of the macular hole, because you need to examine these patients very carefully. You need to decide whether the defective vision is because of progression of cataract, if they have the human lens inside the eye, or whether it's because of the progression of the epiretinal membrane resulting in decrease in vision. and the tractional element is increasing on OCT, and you need to assess the visual potential, meaning thereby the integrity of the outer retinal bands. Now, this is one of the cases that I operated. You can see the OCT. It's a long-standing epiretinal membrane there with a lamellar macular hole. You can see the outer retinal bands are reasonably well seen. The visual acuity was quite bad. I advised the patient surgery, and he did come for surgery. Now, as far as the surgical technique is concerned, now this is the vitrectomy. There is a little bit of glare in the video, and unfortunately the resolution in here is far less than what I saw in my laptop. You can see here the vitreous is very different from what we see in a normal case of an epiretinal membrane. You see a lot of membranes there and condensation of the vitreous, unlike what we see in a normal case of an epiretinal membrane or macular hole that we operate upon. You induce the PVD, this patient did not, and you can see here I'm removing the epiretinal membrane, which is quite a large area, and I'm not using the contact lens, but I'm using the 60D Resight lens for this because it was quite a large area, and I removed the ERM in one go. After that, I stained with the brilliant blue so as to remove the epiretinal membrane, and the ILM, And the ILM, if you see here, the ILM, normally in a normal epiretinal membrane, the ILM usually comes off in bits as we remove it. But here the ILM was present all over. And I slowly removed the ILM. It came off in bits and pieces. And I just did an air exchange, no gas. And following surgery, 3 weeks, you can see here, there is an improvement. And when you see it 3 months post-operatively, there is significant improvement, at least anatomically. But visually, there was hardly any improvement after surgery. So lamellar macular holes recently, there is a publication, very interesting, where they have classified it as 2 distinct clinical entities. One is what they call as a degenerative lamellar macular hole, where the base is very broad and probably secondary to chronic cystoid edema, etc. And the other is what they call as the tractional lamellar macular hole. So if you see this particular picture here, this is the degenerative type where you see a hump at the bottom and there is loss of the outer retinal bands and the visual acuity is very poor. And this is the better type where the outer retinal bands are present and the visual acuity is very good. So in conclusion, the pathogenesis is still controversial. There are new concepts based on ST-OCT. Although the natural course is favorable, there are some patients which may need surgical intervention, and the role of vitrectomy in early cases is still debatable. Thank you.
Thank you, sir. Since we have 2 more talks, I request Dr. N.S. Muralidhar to give his talk on vitreomacular interface disease in diabetic retinopathy. There is time towards the end of the session. We will have some questions. Dr. Muralidhar.
Thank you, Giridhar, and good morning, everybody. I'm going to talk about vitreoretinal interface in diabetic retinopathy. We all know that vitreoretinal interface and anomalous PVD is an important component of diabetic retinopathy, and it is the chief cause for complications of PDR in terms of traction, detachment, vitreous hemorrhage, etc. However, when it comes to diabetic macular edema, the vitreoretinal interface plays a much less well-defined role. This is a patient who came to us with defective vision in her left eye. There was a macular edema, diffuse variety. We did an FFA, it shows kind of a diffuse leakage. However, the OCT shows the true picture of vitreomacular traction. A lot of it has been talked about by the previous speakers, but important thing is it can present as a diabetic macular edema, and only the OCT can differentiate this tractional component. And following surgery, of course, this patient did well, and without the OCT, probably would have ended up treating her like a diabetic macular edema. So DME, primarily that presents as a macular edema, and treatment is intravitreal injections and possibly some laser. But there is a small subset of patients who have this tractional component and who need surgical intervention. It's important to recognize and plan intervention in these patients. And clinically, it may not be possible for us to differentiate and pick up these patients, and OCT is an invaluable tool in diagnosing and managing these patients. You can broadly classify these vitreomacular interface abnormalities in macular edema into epiretinal membranes and anomalous vitreomacular adhesions like VMA, VMT. A lot of it has been talked about already, so I won't repeat it. I'll just show you clinical examples. Basically, the two subset of patients with diabetic macular edema who would need surgery. One is DME with abnormal vitreomacular adhesions and proliferations. There is a second group, which is an ill-defined and controversial, debatable group, which is a recalcitrant macular edema, which does not respond to your injections and laser. But there is no tractional component in them. Will vitrectomy help in these patients? Let's see sometime later. So let's look at some of these entities, VMT, VFT. Just like in a non-diabetic patients, even in a diabetic patients, VMT and VFT can occur. OCT clinches the diagnosis. You see this patient who presented with 6/36 vision. And let me tell you, we don't jump in and offer surgery at these patients because spontaneous separation is reported, as Giridhar pointed out, by various studies. So we waited for 1 or 2 months. 1 month later, the traction increased, and we went in and did surgery. And of course, this patient, we were able to relieve the traction and vision improved to 6/18. Taut posterior hyaloid phase is seen clinically. Often it's a component of PDR, and OCT is an invaluable tool to study. But let me tell you, I find it difficult to decide surgery in a taut posterior hyaloid phase because it's difficult to interpret how much this traction is really causing decrease in vision. When it is something like this, it's quite easy to decide to operate, but in situations like this, when you're not sure what is the contribution of the taut hyaloid phase to the decreased vision, it's difficult to decide to operate. Epiretinal membrane often present as a coexistent in the NPDR and PDR also. And OCT is invaluable in picking it up, but again, difficult to assess the effect on vision. I'll show you an example. This patient came to us. He had received on and off some intravitreal anti-VEGF earlier, and he had poor vision, 3/60. You can see macular edema. There is an ERM there. And because patient had not received anti-VEGF on a regular basis, we gave him 3 injections. Vision did improve to some extent. Edema did reduce, but not substantially. Now we were debating whether to remove the CRM because here is a patient who has not responded to your injections. And as a final trial, we said, let us try an intravitreal triamcinolone. It had not been tried. And here you can see, following the IVTA, the edema has come down. ERM, however, is still there. VMA is still there. Again, here we are in a dilemma. Whether surgery is helpful in this patient. IVTA has reduced the edema, but vision has not improved terribly. Will the surgery prevent a recurrence of the edema? 3 months later, if the patient gets the edema again, should we inject IVTA or should we combine IVTA and a surgery? We don't have answers to these individual cases. There's another patient in whom this decision to operate was quite straightforward. Right eye vision was 6/18. She came with defective vision in the left eye, 3/60. And you see, this ERM is definitely something that is causing a macular edema and traction. Here, we can be sure that the tractional component is more. One of the things I look for is something like some of these folds. If there is edema is the primary pathology, ERM is an incidental finding. I find that though there is no gap like this in the OCT. And following surgery, of course, 1 month post-op picture we have, vision improved to 6/36, probably she will improve a little bit more. So this is a patient where decision to surgery was much easier. This last subgroup of patients are those patients who have no abnormal vitreoretinal traction, but they have had several injections, steroid, anti-VEGF, and they are not responsive or they are recurrent. So vitrectomy has been advocated in this subgroup of patients. They say that if you do vitrectomy, peel the ILM, the edema resolves. However, I have never been convinced that vitrectomy is the answer for these patients because I have found that although the edema resolves, the vision never usually does not improve. So I don't have very large series of these patients. Now, as far as surgery for this subgroup is concerned, MIVS is the way we go. And most of these patients coexistent cataract. So combined surgery will be required in many of these patients. We do peel the ERM either with the tricot or with brilliant blue. And ILM peel, again, most often we end up doing. But in those patients, as Mahesh pointed out, when there are cystoid changes, large cysts close to the foveal center, be very careful. You don't want to deroof. So one of the things I have found useful is to do the fovea sparing ILM peel, where you peel the ILM up to around the fovea, but don't peel it off the fovea, and then trim the ILM up to that place. And that can probably reduce the risk of causing a lamellar hole or a full thickness hole in these patients. Just a small video to show. This is a 25 gauge vitrectomy being done for vitreomacular traction. I have used triamcinolone to stain the vitreous, and you can see that there is also some PDR coexistent in this patient. In this patient, I did not use brilliant blue. The tricot staining itself was enough to allow me to peel the ERM and the ILM in this patient. And I did not need to use a foveal sparing technique in this patient because he did not have such large cystoid spaces at the fovea. As Mahesh pointed out, use of small amount of triamcinolone may help in reducing the edema these patients do have in the postoperative period. And this patient, we also did a PRP because patient had a early PDR. I think we'll skip the video because we don't have time. Okay, let's go to the largest series of patients who have been operated for vitreomacular traction from the DRCR network, who evaluated 87 eyes with VMT and OCT. The mean pre-op visual acuity was 20 by 100. Vitrectomy and ERM peel and with ILM peel in some patients was done. 6 months, the median OCT decreased by 160 microns. About half of them, it decreased more than 250 microns. And visual acuity improved in about 1/3 of patients, and it reduced by 10 letters in 22%. This is the series of articles about vitrectomy in those eyes who have no vitreofoveal traction or no tractional component. And most of these studies are small series. We don't have large series. We don't have uncontrolled series. And most of them have shown that there is a variable result. So today we don't really have a definite answer whether vitrectomy is the answer for these subgroup of patients. So some of the studies have shown that no significant visual improvement. Some have shown that about 43% have improved. However, we don't have large series of vitrectomy for a non-tractional diabetic macular edema. So in conclusion, it's important to recognize that there are small subset of patients with diabetic macular edema where the tractional component is an important pathology, and this needs to be suspected and recognized. And today, without OCT, I don't think we can really diagnose and treat these patients, and they have to offer surgery for these selected situations. Whereas, however, the role of vitrectomy in the absence of tractional component, to my mind, I don't think I'm really convinced about that. In spite of having the traction and removing, it's not necessary that we get good results in all the patients. We have to warn the patient about the modest improvement that they can expect in these subgroup of patients because of the underlying diabetic pathology also. Thank you very much.
Thank you, Murli. And just one comment. I think there is a lot of, the one main difference between what we see in a diabetic situation and an idiopathic situation is we should always remember whether this is part of what we call as a vitreocysis. So the membrane that we see which is raised may not be the posterior hyaloid, and there may be one more membrane underneath it attached to the retina. So we should not miss the second layer in patients with diabetic vitreomacular traction syndrome, and this is a very important take-home message. So we need to move forward. This is the last talk. This is a keynote address by Professor Sulaiman. Please come, sir. He is a professor of ophthalmology at the... Sir, I would just like to introduce you. My pronunciation may not be very correct. Please pardon me for that. Dokuz, can you just introduce yourself, sir? Can you just...
Dokuz Eylül University in Izmir.
Okay. Thank you, sir. Thank you.
Thank you, Chair. Good morning, good morning, everyone. First of all, I wish to thank the organizing committee for inviting me here and to be here with you. And I am going to talk about the controversies on epiretinal membranes very shortly in 10 minutes. So there are a lot of controversies. Firstly, for example, nomenclature is a very controversial, as you see here, but recently epiretinal membrane terminology has a consensus. And also, there are some grading systems about the epiretinal membrane, and mostly 30 years ago, Gus had performed a grading system, but before OCT, of course. Now we try to make some correlation with the Gus classification and OCT findings and classification of International Vitreous Attraction Study data, and we try to make a correlation, all of them. And at the same time, we can see a lot of structures in the cellular glial cells, retinal pigment epithelial cells, and other cells in the specimens of the epiretinal membranes. So, different percentage of those cells can be found in the specimens of epiretinal membranes. Also, we can make some correlation with the etiology, mechanism, biological mediators, and so on in the different epiretinal membrane formations. Actually, the problem started with the posterior vitreous detachment, and sometimes the posterior vitreous detachment can be seen incomplete, and at that time we can see some problems, tractional and pathologic changes on the surface of the retina. So sometimes, as you see here, the complete posterior vitreous can be seen, but sometimes some parts of the hyaloid tissue can be seen still on the retinal surface. So we can do some algorithm about the epiretinal membranes. The aging is the starting process in the vitreous liquefaction seen after aging, and complete PVD can be seen in epiretinal membrane after complete PVD, and the partial PVD, full thickness, and lamellar hyaloid separation can be seen in different cases. And after full thickness partial PVD, we see posterior separation and the retinal tears and detachment in some cases. And peripheric separation and posterior adhesion can be seen. At the end, we see vitreopapillary traction or vitreomacular adhesion and vitreomacular traction. And at the end, can be seen epiretinal membrane formation as well. After lamellar hyaloid separation or vitreoschisis, we see premacular membranes, and centripetal contractions goes to the epiretinal membrane, and sometimes centrifugal contraction can be seen, goes to the macular hole. And we see this algorithm, the epiretinal membrane formations, comes different etiologies and different processes. And also, we can make some algorithm about the surgical intervention and indication of the epiretinal membranes. Here is the symptoms are very important, visual acuity and others. And if we see the epiretinal membrane more than 1500 micrometer, we think about the surgery as well. Here is the incomplete posterior hyaloid detachment, and sometimes we see just only vitreous liquefaction, and as you see here, the posterior vitreous cortex still lying on the retina, and at that time still we see some epiretinal membrane formation, and sometimes real complete posterior PVD, posterior vitreous detachment can be seen, and in those cases also we see epiretinal membrane formation, and sometimes posterior vitreous detachment might be seen incomplete, and between the part of the posterior hyaloid also we see some epiretinal membrane formation. And lastly, vitreous schisis. As you know, layers of the posterior vitreous cortex are separated, and we still see some epiretinal formation on the outer layer of the vitreous schisis. So the prevalence mostly 10% after 8 years old, and the risk factors are age, diabetes, and hypercholesterolemia. And the indication of the surgeries depends on the tractions and vitreomacular adhesion and macular hole formations, besides of the epiretinal membrane. Visual acuity, metamorphopsia, and central visual field defects are very important for the indication of the surgery, and the visual prognosis depends on the macular thickness, ganglion cell layer, and the ISOs and external limiting membrane structures. Metamorphopsia is very important in those cases for the surgical intervention, and metamorphopsia associated with thickness of inner nuclear layer and ganglion cell layer thickness, and also architectural disorganization of those layers. And the decreased visual acuity also correlated with the macular thickness and integrity of ISOs and external limiting membrane formations. As I said before, metamorphopsia associated with the inner nuclear layer and correlated with its thickness, and also the metamorphopsia correlated with the decreased visual acuity. How can we evaluate the prognosis? There are several classifications as a clinically diffuse thickening and the vitreomacular traction cases, a little bit better visual outcome than the other forms of epiretinal membrane. As you see here, diffuse epiretinal membrane gives a little better postoperative macular contour other than other formations. And also here is the vitreomacular traction cases has a little bit better visual outcome than the others. Should we peel the internal limiting membrane? In my experience, ILM peeling reduces the recurrence risk, but the visual outcome may not be so much different, and therefore the additional internal limiting membrane peeling procedure should be preferred. And actually we see in some specimen epiretinal membrane and ILM together in some cases. Should we use dyes? Of course, it's a very controversial. We use triamcinolone acetonide for identifying the vitreous tissue in the posterior hyaloid easier in the surgery. And tripambilou as a cellular dye is a very good facility to see and identifying the epiretinal membrane border, and it's very easy to remove the membrane during the surgery. And brilliant blue as a collagen dye is a very good facility for the internal limiting membrane peeling, and it's very easy to identify it during the surgery. Sometimes we use double staining, and sometimes we use blue dual, which is the combination of tripambilou, BBG, and polyethylene glycol. And it's very easy to remove with these material at the same time epiretinal membrane and ILM. Should we inject the gas? We use actually SF6 mostly because of the average duration, large size, and average expansion. And sometimes we recommend that to patient for face down position. Even some people defend it is not necessary to positioning, face-down positioning, especially in the macular hole surgery, we recommended to our patients approximately 3-4 days for face-down position. Actually, our preferences in our department, pars plana vitrectomy in epiretinal membrane patients who has some decreased vision, metamorphopsia, and central scotoma, 23, 25, or 27, and we use triamcinolone and trypan blue and brilliant blue as well. Sometimes we need laser to peripheral retina and air fluid exchange we do in face down position for 3 days. Lastly, is there any indication enzymatic vitreolysis in those cases? And the last recent papers showed that there is no indication in those cases in enzymatic vitreolysis. Actually, the take-home message, surgery, especially visual acuity, metamorphopsia, and scotoma are very important criteria. The earlier the surgery, the better the functional outcome. And OCT is very important, of course, about the ganglion cell thickness and ISOs. In a 25-27 gauge surgery could be used properly. Triamcinolone and dual blue for staining is proper, and ILM will be removed with IRM for preventing the recurrence rate, and SF6 might be proper for short-lasting tamponade, and face down not mandatory, but 3 days may be recommended, and combined surgery, if necessary, may be performed, and ochriplasmin is not indicated in the epiretinal membrane formation. Thank you very much for your attention.
Thank you, Dr. Sulaiman, for that very nice talk. We do not have any time for discussion on this particular topic. And thank you all for your presence here, and I hope you enjoyed the course. And thank you all the instructors.